Good morning, colleagues. As Dr. Sim already said, I would like to speak about this advanced analysis of the fetal heart with speckle tracking. It is, as he already said, a new technique, and I would like to show you within the next slices what we can already do with this technique. I mean, everybody knows with the introduction of fetal echo, we had two main aims which were set. This was first of all the identification of congenital heart diseases, and secondly, the quantification of cardiac function. And I've just listed the situations in which monitoring of the fetal cardiac function is mandatory, or in which it makes some sense. As you can see, volume or pressure overload, hypoxia, hypoglycemia, heart compression, or myocardial damage. And speckle tracking is one of these techniques, besides, for example, tissue Doppler imaging, which gives us the possibility to assess myocardial deformation. How does it work? Speckle tracking is a non-Doppler dependent technique, and this is, in my opinion, one of the most important advantages, because it's more or less angle independent. We know Doppler is angle dependent, but speckle tracking is more or less not angle dependent. It's based on a frame-to-frame analysis. You have a kind of fingerprint of your B mode picture, which is caused by scatter echoes, and with a region of interest you can put on your screen in a special part of the cardiac muscle where you can place your ROI. This will be followed, this area will be followed within the consecutive pictures. As you can see in this table down there, there are different vendors which have this tool on board. There are several papers already published. More or less, when you compare these data, then you get to notice that they are not really comparable. That's one of the main problems. But we'll focus on the wall motion tracking we worked with the last years, based on the Toshiba technology. The fourth point you can see here, data analysis based on DICOM or raw data. This is a very important point, because for example, when you read all these published data, you will notice that one point, because they are not comparable, is that dependent on the software you use, it's the point, is this based on the normal DICOM data, which is, as we all know, 30 frames per second, or is it based on the acoustic frame rate, which is the frame rate you can see on the screen of the machine? This can be up to, for example, 200 frames per second or even more. But I will speak about this part later on. Now, how is, for us, the workflow at the moment? How does it work? And as you can see on the left, this is your basic start. The 4-chamber view. You have here the first of all the question: should it be an apical or should it be a basal 4-chamber view? This more or less doesn't matter. You can choose whatever you want to, but it should be one of these two positions. Transversal view, we already tried to do it, and I think because of the lower lateral resolution, you should avoid this. Now, when you see the septum, it should be either between 11 or 1 o'clock or 5 up to 7 o'clock. This is, should be the range where you should measure. Then you should try to narrow your scan range to get, if you are interested in high frame rates, then you should narrow the scan range to achieve these high frame rates. And as you, I think, can see quite good on the screen, it's a very high contrast picture. You need this because the detection of the speckles works much better than if you have a very smooth picture. The acoustic or the persistence of the B mode picture should be set to a very low level, just to see or to get a very good movement within the different frames. When you have this position, you can start your acquisition by just storing some scene loops. And when you start the application, then it's in the middle upper picture, you have a scene loop, for example, of 1 or 2 seconds. And now the problem is we are not in adult echo. We have no ECG triggering, so you have to choose yourself one cardiac cycle according to the opening and closure of the AV valves. And this is be done in the upper loop. Now, if you have this already done, then you can place or you can trace your endocardial border. Yeah, this can be seen here. Just follow the endocardial border, and semi-automatically, after you put your inner line, the outer line will be set by the machine. Yeah? And finally, it looks like, as you can see here on the bottom, the ROI is divided into 6 segments, which can be shown later on a slide. Yeah, you have a basal part, you have a middle part, and an apical part, and then for each side, the lateral free wall and the septal wall. And I think you will agree when you see that this tracking is really synchronous to the movement of the fetal heart. This is more or less the thing we want to have, not only nice pictures, but the graphical illustration of our 6 segments. And additionally, this dotted line is the global longitudinal strain in this case. Now, this just for you an introduction how it works, and within the last 5 years already now, we try to focus on different things. One of the first things was that we know that it's a very new technique, and first of all, you have to see how is the reproducibility and feasibility. Therefore, we performed a prospective study. We included, in this case, 29 healthy fetuses. The acquisition rate, we choose the doubled DICOM rate, in this case 60 frames per second. The machine we used at the beginning was the Toshiba Artida, which you normally not see in fetal echo, because it's more or less for adult echo. But we used this because of the possibility for changing to 3D, which I will speak later on. So Toshiba Artida system, and when you read different papers, you see most of them, or more or less all of them, they use sector probes. We did not. We used a convex convex probe with 1 to 5 megahertz. Because of the fact that the Artida system and comparable systems from other vendors normally need an ECG signal just to record the raw data, ultrasound raw data. We used an additional ECG dummy to get an ECG signal. And finally, the offline analysis, which you have seen on the slides before, was performed with test driver software. And what you can see on the right upper table, we divided it in this basal, middle, and apical segment, left, right, free wall, and septal, and finally the global longitudinal strain. This is all of these data is only the longitudinal strain, and what we can produce, for example, or reproduce in a very good manner is that we could see that there is a basal to apical ongoing longitudinal strain. It's a kind of we have the lowest strain values in the basal parts. We have the highest longitudinal strain in the apical parts, and this is something which we also know from the adult echocardiography. Reproducibility, I'm sorry for this tiny table. Inter- and intra-observer variability, we could achieve a very good intra-class correlation, so we could demonstrate that this works quite well. Another thing which we were quite interested in is, and this is always the same, it's the question of frame rates. So again, this was which is already published. Many of these colleagues, they say more or less we expect that this is because of the need of high frame rates for tissue Doppler imaging. This is something where you need a high temporal resolution, and therefore you can only achieve this by high frame rates. But speckle tracking is different from that. It's the main part. It's not temporal resolution, it's spatial resolution. Anyway, we said we want to know how big is the influence of the frame rate. In the first step, we said, okay, we want to analyze the difference between normal DICOM frame rate, 30 frames, and the doubled frame rate, which means 60 frames. And according to that, we also took two different ultrasound systems, the Artida and the Apleo 500. We included more than 100 healthy fetuses, and as I said, different frame rates, different ultrasound systems. And what we could demonstrate is that there is not a difference, more or less. When you see the red p-values, they are only in 4 segments. All of them are within the septum, the lateral wall, and the lateral free wall, and the global longitudinal strain was independent of the frame rate. Now, this was just DICOM frame rate, 30 and 60 frames, and we wanted to check how's the influence when you take DICOM and acoustic frame rate. And as you can see here, The acquisition rate was, on the one hand, 60 frames of DICOM, and acoustic frame rate around 130 frames per second. We only took fetuses we scanned with the Apleo 500, and what we could see in this case here on the scatter plot and the box plots, you see the difference was not significant. We could show that the acoustic frame rate, peak longitudinal strain values measured by or analyzed by the acoustic frame rates were a bit lower. The distribution was a bit lower in the acoustic frame rate, but it was not significant. So again here, I mean, where this is this analysis is still in progress because we have about 300 patients already measured, and I'm expecting nothing else we already got as information, but as I said, it's still an ongoing analysis. Now, just to show you not only normal cases, as a new technique, you also want to see, okay, how does it work in pathological cases. This is one of our cases we did in Melbourne in an animal model where in a sheep fetus an occluder was placed in the foramen ovale, and we did our analysis before and after the intervention. And when you see, I'm sorry, the laser pointer is not working. I hope maybe it's a bit difficult here. When you see this is before the intervention, very high longitudinal strain values in the apical segments, and directly afterwards, after placing the occluder, you could see that there was definitely more or less nothing left of the apical movement, totally disturbed myocardial motion in this case. Now, away from the animal model, now back to human fetus. This is a critical aortic stenosis in the third trimester, and we did our analysis on the left and the right ventricle, and as you can see here, in this case, which is searching for the mouse. As you can see here, the graph it shows a positive longitudinal strain during the systole, which is completely different to the normal way we are expecting in a healthy fetus. So it seems to be that by this congenital heart disease, also myocardial deformation is completely changed, while the right ventricle shows more or less a normal movement of the myocardium. We have slightly lower longitudinal strain in this right ventricle, which is comparable to data which is published with other systems. Another case, the hypoplastic left heart with endocardial fibroelastosis here on the first of all the left ventricle. I mean, even though we know this ventricle is not useful in this pathological case, but just to show how the myocardial deformation has changed dramatically. You see again here during the systole, you have a stretching of the myocardium, which can be seen in the positive strain values, especially on the apical ones. The right ventricle, it's a bit narrower than normally, but again here slightly lower longitudinal strains values, like already we saw in the cases before. I said we have, this is a new technique. There are definitely some things which need to be changed during the next months, years. One very important step has already been done. This recent consensus paper by the European and the American Society for Echocardiography has published it, and there were put some things together. The different vendors, industry, they said, for example, yeah, we definitely say longitudinal strain, for example, is based on the endocardial border tracking. Yeah, even different vendors, for example, include their whole wall motion tracking, but it's mainly based on the endocardial border tracking. This shifting you normally have, especially in fetal echo, this is something which need to be changed, in my opinion. But during this consensus paper, first step has been done, and we are still working on these problems, which are, for example, fetal movement, maternal movement. This is a thing which is very, very complicated to calculate out of your analysis. It's much more difficult for the tracking itself when both of the patients are moving, but we are still working on it, and I think we will manage this problem. As Dr. Zimmer already said, when we think about the fact that the myocardial architecture is very three-dimensional, then maybe it makes not very much sense to measure this by a two-dimensional method. Therefore, we dealt with 3D speckle tracking, in which you do not have only one two-dimensional plane, but you have a pyramidal volume in which all the vectors can be calculated. And just to show you a few slides, we already published this in 2014. It's a bit different from normal scanning because you are scanning in simultaneously in 3 dimensions with a matrix probe. This is a case of 20-week-old fetus. You have your normal 4-chamber apical view and the perpendicular and the 2-chamber view. When you are confident with this acquisition, then the system automatically creates 3 short axis views displayed on the left side of the screen. And according to the things I told you before, you can see then different possibilities of displaying your results, longitudinal strain, or even the twisting. Now we can skip this because it's the same. Now just to conclude, this speckle tracking is definitely a promising technique, but one of the problems we have to deal at the moment is this extensive training and time-consuming analysis, which is not online, but it's a post-processing analyze. That means when you have your patient and you do your scan, you save your raw data, and when the patient is already at home, that's the workflow at the moment. When your patient is already at home, you can do your analysis, because it's set. At the moment of the workflow, it need to be changed, but this is not a not a Toshiba problem. It's a problem which all vendors have, and I mean it's very interesting to see what technicians and engineers are able to produce, what you can measure, but we all have to ask ourselves of the clinical values of these derived parameters. And so, yeah, the additional benefit in pathological conditions need to be evaluated. Thank you very much.